Good afternoon, everyone, and welcome to our first Women's Mental Health webinar of 2021. My name is Mary Hayes, and I'm the Women's Health Policy Officer for the National Women's Council and one of the coordinators of the Women's Mental Health Network. So first of all, I'd like to welcome our network members this afternoon. I'm delighted to announce that we've just reached over 300 members, so that's absolutely fantastic. We're so happy to see the network growing and developing and to continue learning together about women's mental health. So for those of you who aren't members of the network or who aren't familiar with us, the Women's Mental Health Network is a joint initiative between the National Women's Council and St. Patrick's Mental Health Services. The network launched back in 2018, and it's a network of people and organisations with a committed interest in women's mental health issues. So in our work, we aim to provide a forum for information sharing and networking and to advance interdisciplinary and multi-agency collaboration on women's mental health issues. So throughout the year, we organise education and networking events, and these are hosted collaboratively between the National Women's Council and St. Patrick's Mental Health Services. And we share information and resources on women's mental health through newsletters and online updates as well throughout the year. So if you'd like to sign up to the network, it's very simple and free, and we'll circulate a link to join after the webinar today. So we're delighted to see such a huge interest in the webinar, especially being the week of International Women's Day. It's been our highest subscribed event yet, which is fantastic to see and clearly demonstrates a growing need for focus on women's mental health. So today we'll be taking a broad view of how the pandemic has impacted women's mental health a year on from when COVID began to take hold. In the Women's Mental Health Network, we're very conscious that particular groups of women have been disproportionately impacted by COVID. And we recognise the needs of marginalised women, like women in the traveller community, the mental health of women seeking asylum, and disabled women, to name just a few. We recognise that by no means have we a fully representative panel today, or are we able to explore the full diversity of women's experiences within the scope of this particular event. Our aim with today is to start off with a very broad overview and perspective on women's mental health during the pandemic. We're looking forward, however, to more focused events over the year, where we can ensure that we'll hear from a diversity of voices and have a focus on the different lived experiences of women. So we'll keep you posted on these. So this time last year in the Women's Mental Health Network, we were looking forward to an in-person event in St. Patrick's Mental Health Services, which of course was postponed indefinitely after the country went into lockdown. A year later, much of what we feared would disproportionately impact women during the pandemic has persisted and continues to have an impact on women's mental health. Women have been under enormous pressure over the last year. The majority of frontline workers in health, retail and domestic roles are women. Women have been providing the majority of care for children, older adults and adults needing further support. And lockdown has been especially challenging for women parenting alone. Women in abusive relationships have been under lockdown with abusers. Pregnant women have been impacted by continuing restrictions in maternity hospitals, and women's voices have been excluded or actively ignored in the response to the pandemic. So in November of last year, the National Women's Council published a report on women's experiences of caring during COVID. And this was based on a survey of over 1,400 women. We asked women to self-report on the informal, unpaid care work they were providing during the pandemic. And this would have included things like minding children, housework, care for older family members, care for loved ones' older or emotional needs, and how these had increased during the pandemic. So what we found was 85% of women said their caring responsibilities had increased, and 55% of women said they had less time to look after their own mental health and well-being. So looking to today, the theme chosen for this year for International Women's Day is Choose to Challenge. And COVID-19 has brought a new visibility to the needs and inequalities within society. And if we grasp it, the potential to restructure society and move from crisis to change. So in this webinar today, we wanted to look at opportunities for social change, advocacy and action as we move towards the recovery phase of the pandemic. So we're delighted to welcome our panelists today who will further delve into these issues. So joining us today, we have Dr. Clena Nickalick from COVID-19 Women's Voices. She's also a consultant in general medicine and infectious diseases and clinical lead for inclusion health research at St. James's Hospital. We have Dr. Mark Ward, who's a research fellow with the Irish Longitudinal Study on Aging, otherwise known as the TILDA study at Trinity College Dublin. And we have Fiona Coyle, who is the CEO of Mental Health Reform. So just a couple of housekeeping pieces before we kick off. So for anyone tweeting, please be sure and use the hashtag Women's Mental Health. We're also mindful as we discuss these issues today that many, if not all of us, joining will understandably have experienced some impact to our own mental health over the recent weeks and months to one degree or another. Whether that's been feeling sometimes anxious about ours or others' health, having disturbed sleep perhaps, or finding it harder to concentrate or be as productive at times. We're also conscious, as with all our events, that some of the topics we'll be looking at today may be challenging for some, and we'd really encourage everyone to look after themselves in this regard. We will be having a 5-minute break, so please do step away from your device if you need a little space. You don't need to exit the webinar, you can just leave it open, but if you do accidentally exit out of it, you can just click the link that you received in the email this morning. Finally, your participation is very important to us in the Women's Mental Health Network, so you can use the Q&A function throughout the webinar to add questions or comments for our panelists. These won't be visible to everyone, but we'll be working in the background to collate the main themes and share comments and questions with our speakers during the second half of today's webinar. So first, I'd like to welcome Fiona Coyle from Mental Health Reform. So Fiona, if you'd like to turn on your camera and audio. Hi, Fiona. How are you?
Hi. Good. Can you hear me okay, Mary?
I can, yeah. It's great to see you. I've seen a lot of you this week, which is always a treat. So we're delighted to have you here today.
Yeah, it's great.
So for anyone who's not aware of Mental Health Reform, if you'd like to just tell us about yourself and the work that you do.
Yeah, so thank you so much for asking me to speak here today. So my name is Fiona Coyle, I'm the CEO of Mental Health Reform. So Mental Health Reform is Ireland's national coalition on mental health. We're a membership-based organisation. We represent nearly 80 organisations. Our organisations come from a diversity of backgrounds. So some of our organisations implement mental health services themselves, such as Jigsaw and Pieta. Others represent, special interest groups such as the Kidwa or Pavi Point. But what all those members have in common is that they all believe that we need to reform Ireland's mental health services and supports, that they're currently not meeting the needs of the Irish people. So we provide a platform for our members to come together, and we try as much as possible to speak out with one strong voice towards government and other key stakeholders on the need to really prioritise, invest in and ensure our mental health services are fit for purpose for those who need them. Oh, you're on mute, Mary.
Sorry. That's great. Thanks, Fiona. And I suppose it'd be great to hear what you think the key impacts and issues are at the forefront of advocacy for women's mental health at the moment.
Yeah, I'd be delighted to have lots of thoughts in this area. It was really interesting, you noted that, the theme of this year's International Women's Day, Choose to Challenge. And we have a lot to challenge. There's so many inequalities that exist. What was interesting, my experience of International Women's Day, I checked my personal email and I had a lot of companies emailing me, wishing me a happy International Women's Day. And it made me pause and go, happy? Really? Are we? This is not what it's about. And, I was reflecting on, in Europe, women are more at risk of poverty. During COVID, women are disproportionately represented as frontline workers, we know, in health, in retail, in domestic roles, school, childcare. I'm sure lots of women listening today were put under so much additional burden to look after their young ones, especially lone parents, which we know are disproportionately women. Many women had precarious jobs before the pandemic, have now lost those jobs. Women in abusive relationships have been locked up with their abusers. So, you know, COVID has really just shown how it's really exacerbating those gender inequalities and intensifying them. And you may ask, so what's this to do with mental health advocacy? Well, social inequality is very intrinsically linked to mental health difficulties. Poverty, abuse in the home, financial insecurities, these all have tangible mental health outcomes. COVID has exposed these, but I think, you know, that's my kind of first message is women's mental health advocacy. It's about addressing social inequalities because we know how strong that link is, and we really need to have that front and forefront center of everything. Secondly, it's about services and access to services. We've really, as mental health reform, have been pushing for the need for person-centered mental health services. What does that mean? We're all different. Everyone's mental health journey is their journey, and people need different types of services and at different points in different locations. And women in particular, you know, really need services that reflect their lived experience. And, you know, the National Women's Council, you've done some interesting research around that, but, you know, we need to ensure that women and our needs are taken into consideration. Like, you know, if you think of even like perinatal mental health services, very specific to women, you know, historically very neglected and under-resourced, but it's ensuring that our services respond to women. Services that, as we know, are hugely underfunded as it is. So, you know, we need to ensure that we're putting pressure on to say we need investment, you know, to government and others. We need investment, but that's not good enough. We need services that respond to the needs of women. And even within that, women were such a diverse, as you also outlined, Mary, diverse group. Like women, traveller women's access needs may be so different to women from different kind of cultural backgrounds. And it's so important that as we're developing mental health services, we're taking into consideration this difference approach, that we all are really different.
Yeah, absolutely, Fiona. And you've made some great points there. You know, COVID really has exacerbated those kind of social inequalities that we know from research have an impact on women's mental health. But I think it has, you know, changed people's view, I suppose, of women's contribution to other people's lives, to the caring infrastructure. So I suppose my next question would be, what do you think are the real key opportunities for change as we move forward?
Yeah, you know, it is, we're all living through a pandemic. It's a global crisis. There's no getting away from that. But, you know, at a time of crisis also brings opportunities to address some of those, you know, more intrinsic kind of cultural norms that are embedded in our society and in our thinking. And I think, you know, going back to that kind of social justice issue, like for so long in this country, mental health was discussed as a very individual issue, that it's to do with the person's kind of biology, and there was very little discourse. You know, in the last 10 years it's growing more and more, but, you know, I think COVID has really shown people, actually my mental health, it is impacted by my social circumstances. And I think there's an opportunity in that, and there's an opportunity that people now recognize that mental health is really important, you know, and our systems and our services were not fit for purpose before COVID. They were in crisis. There were over 10,000 people waiting for primary psychology appointments. So, you know, at that macro level, there's lots of opportunities. But then, you know, last year, we also had the launch of a new mental health policy. So, you know, without COVID, that's a huge milestone in mental health. It's to guide the next 10 years. And in that policy, you know, there's a lot of opportunity to develop gender sensitive mental health services across the country. You know, it's the first time that gender, kind of in gender mainstreaming, has been mentioned in a policy. And, you know, it really, I suppose, it really puts an emphasis on our services to respond to the needs of the individual. And there's a specific recommendation, Mary, as you know, you've been working on it as well, around, you know, there's a Department of Health Women's Task Force, and there's also a National Implementation and Monitoring Committee that I sit on to ensure that the policy is implemented and there's oversight, but that those two groups will, within 12 months, look at doing a joint project to look at the mental health needs of women and girls. And, you know, I think that is really positive, that it's in the policy, there's an action, it can be held accountable. So I think there's a huge opportunity, you know, to recap, to ensure that we're using this focus on mental health. Like, never, certainly in my lifetime, have I seen such mental health being included in public discourse so much. You know, it's there, but the voices, those diverse voices, are not coming through. So that's what we need to work and need to challenge. But then we need to move further and ensure that this mainstreaming, this difference approach of women and other kind of other groups who may need specific services is really taken into account at that service level. So I think there's a challenge for us all to keep this on the agenda and to ensure that, you know, we're speaking out on it. But lots of opportunities, I think.
Yeah, absolutely. And I suppose, you know, seeing gender recognized and sharing the vision, it was a relief, and it was great to see it in there. But, you know you're a champion for implementation. Policy is only the first step. So I suppose in order that pressure needs to be kept, the pressure needs to be maintained, basically.
Yeah, most definitely. And I think Ireland has, you know, lots of people on this call will know that Ireland has no shortage of good policies and actions and documents. But, you know, the paper doesn't change people's lives. We need action, and for action, the most of the time you need investment as well. So, you know, we need to keep our voices loud and keep the pressure on.
Absolutely. Well, thank you so much, Fiona. We'll welcome you back in for the panel discussion later on. So next up, we've got Dr. Clena Nickalick, who is a member of COVID-19 Women's Voices. She's also a consultant in general medicine and infectious diseases, and she's the clinical lead for inclusion health research at St. James's Hospital. So, you have your camera on, that's great. So,
can you see my slides, Mary?
We can, yeah, it's on, it's not on presentation.
Yeah, brilliant.
Oh, there you go. Yeah, that's perfect, yeah.
Yay, technical dynamic.
Fire away, will I?
Sorry?
I'll just let you fire away.
Brilliant, thanks a million.
No problem.
Great. Sorry, it's doing something funny now. So thanks a million. I'm really delighted to be invited to talk, and I'm really looking forward to I enjoyed Fiona's presentation. I'm looking forward to Mark's and to the discussion. So I'm here to represent COVID Women's Voices. So just to tell you a little bit about that, it's a very informal group of women. It's a very mixed, diverse group, all kind of through personal contacts, mainly initially. Lots of healthcare workers and academics in the group, but people from all walks of life. And we're really keen to have as diverse a group as possible, and to make sure that we're not excluding women from minority groups and other groups that tend not to have their voices heard. So keen to amplify voices for women who may have more difficulty in getting their messages out there. We're on Twitter, so if you want to join the group, you can contact us through Twitter, and we would love to have you on board. So I think this group came together at the start of this third wave with a sense of we just can't do this anymore. Really, I suppose, personal impact of COVID on all of us and on our lives, and seeing that the effect that COVID was having on everybody nationally, and particularly on women, and just feeling that we couldn't keep going as we had been going, with our voices not being strongly heard in terms of policy and planning, and then as a result issues that disproportionately affect women being ignored, with issues that disproportionately affect marginalised women being ignored even more. And I've outlined, we've got a number of subgroups at the moment. So we have a healthcare worker subgroup because lots of us are healthcare workers, and a group particularly focusing on the mental health of staff and how to support that throughout the pandemic. We have a group for Black women and their allies, another group for female academics, and I'm the lead on a group that focuses on health equity. And we have a leadership group where essentially we just encourage each other to keep going and to let our voices ring out. And what we're asking for at the moment is that there is increasing representation of women at key decision-making groups. For example, the Cabinet COVID subcommittee didn't have any woman on until Helen McEntee joined in October, and then she's now leaving on maternity leave. So unclear as to how that is going to work. And I think that lack of female voices at high levels has been very clear. Something that was very stark as a healthcare worker and a female was the lack of planning for childcare for healthcare workers throughout all the waves when schools and other childcare facilities were shut, and a huge amount of juggling and burden disproportionately carried by women due to that. And I find it hard to believe that anybody making those decisions around working from home while caring for small children, or not having any plan to address the lack of childcare, was made by anybody who had any experience of being the primary responsible person for small children, because it just ain't possible to do much work when you've got small children, nor can you leave small children at home unminded if you're a healthcare worker and you have to go into work. I think what's really worrying us is the fact that there is still no plan for childcare if a fourth wave does hit, and people have been juggling amazing situations for very long periods of time. And this also, of course, extends to other unpaid care work, like caring for elderly relatives or family members with disabilities or other needs. I think another very stark example of the lack of diversity in decision-making processes was around the ban on retail for children's shoes and clothes. So children grow, so when you must buy new shoes and new clothes for them as they grow, and they're back at school without access to shoes and clothes. And again, this has a socioeconomic dimension in that those of us who, like myself, who are more well off can order online, but that's not necessarily something that's accessible or affordable for many women. So just a really clear lack of planning and of being aware of what issues are like for the diverse population in Ireland. So I've been asked, what do I see as key issues for advocacy from COVID Women's Voices? So I've alluded to them a little bit there. I think the first thing is the very strong effect that COVID has had on mental health in general. So increasing rates of psychological distress nationally, with being female being a significant risk factor for being at increased risk of psychological distress. And this is particularly, so about 20% of people in the general population experience increased rates of psychological distress due to COVID, and this is up to 40% in healthcare workers. So healthcare workers are 70 to 80% female, and COVID has had a massive impact on them in terms of their mental health. We've been exposed to very traumatic, having to witness very traumatic scenes at work, having had to move to areas with new responsibility. And I think, while trying to juggle our other responsibilities, and that has been very challenging on people's mental health. There's also the issue of long COVID. So healthcare workers, particularly high risk group for getting COVID, particularly in early 2020. And we know that up to 10% of people who have COVID get long COVID, which is a syndrome of fatigue. It can be associated with depression and anxiety, breathlessness, difficulty remembering, difficulty concentrating, and again, increased risk of this in women. And I've already alluded to the massive issue that the lack of planning for childcare for healthcare workers, when many formal places where children go during the day were shut, has been particularly problematic. So this is just some data from work we've done here on James's, just looking at the difference in risk of post-COVID fatigue or long COVID between men or women. And you can see that of those who were fatigued, nearly 70% were women. Of those who weren't fatigued, only 40% were women. And this is probably due to biological differences in immune responses to COVID. This isn't, as I've had to point out to a few of my colleagues, because women are wimps. I think something that Fiona has already and Mary have already alluded to is the particularly strong effect of social exclusion and inadequate social provision and policies on women. And I know this from my work in inclusion health, where I work with women who are homeless or who use drugs. And in that instance, we see a flipping. So normally women live longer than men. Women have a longer life expectancy. If you're socially excluded, if you're a homeless woman in Dublin, single homeless woman in Dublin, the average age of death for these women was 38 compared to 44 years for men. And women who are socially excluded are particularly at risk of being victims of sexual violence and domestic violence and other adverse events. And I think we've seen this in COVID. So again, that, you know, having money and having access to social resources buffers you against some of the more difficult parts of being female, and socially excluded women don't have that, and that's been very clear. Domestic violence and the increase in domestic violence has already been alluded to, and again, this disproportionately affects women from poorer backgrounds and certain minority groups, and is very, very difficult. What is the answer? Well, I think one of the things is around getting female voices and diverse female voices into the decision making. And one place where that's very, very clear in Ireland, and I was delighted to hear that RTE Primetime featured this yesterday, was on the lack of resourcing and lack of a significant role in determining policy of our public health doctors and their teams. This is they're 90% or more female, they're not paid as consultants, and they haven't been at the decision-making table, unfortunately, and they haven't been resourced to do their jobs. And these are experts in public health who could really have helped us significantly in avoiding the number of cases and the you know, strictness of the lockdowns that we've had to go into. And unfortunately, they still haven't been resourced and still don't have pay parity with their other more male-dominated professional colleagues. I think this is really nice to see. So countries with female leaders tend to do better in COVID, and this is a correlation. I can't say that it's causative, but if you look at countries that tend to have done particularly well in this graph, which is from the Financial Times, you can see that countries like Norway, Finland, New Zealand, Germany, Iceland have done much better, both in terms of their death rates and in terms of their economic performance. And I'll come back to this in my final piece on where I think things should go. Just to highlight this a little bit more, and more rigorous testing strategies is one possible reason that female leaders have had better outcomes. They also have been reported to be better at getting consensus and getting people to buy into often onerous restrictions and listening to the more diverse voices. And that may be something to do with how we're socialized, but it is worth noting. So where do we need to go now? And I think actually what I want to come back to is this graph, because I think this shows us some things that we can learn from COVID that will benefit women's mental health, will benefit women, will benefit all in society. And one of those things is that public health and economic growth are not mutually exclusive. And in fact, in economic terms and in health terms, we do better when we make decisions that will benefit the majority of people and will benefit those most vulnerable in society, rather than allowing pure economic growth interests or the interests of the few to stand over the interests of the many. And I think it's interesting then to reflect on how do countries with female leaders recognize that better. And again, that may just be a correlation rather than a causative thing, but it is worth thinking about what can we learn from the ways that women are socialized to work, or women are socialized to think about the world. What can we learn from that to think about where we want to go going forward? And we know that more fair and more inclusive societies benefit mental health, not only of those who traditionally are marginalized, but even for those who are more privileged, and particularly so for women. So that is me done for the moment. I'm looking forward to the questions.
That's fantastic, Clena. Thank you so much for letting us know about all your work. I'm sure everyone saw the letter from COVID Women's Voices that was published in the Examiner. So it's great to see the way that you work, and you work in such an intersectional way as well, which is obviously very important. And, you know, it's great to see the research and the evidence showing that countries with female leaders, you know, the outcomes are better, but it's, you know, it's about who are the women at the decision-making table, who are the women who are excluded.
Absolutely, absolutely.
Well,
and I think maybe being, you know, being a woman and in some ways being marginalized hopefully sensitizes, but not necessarily, but you would hope that it sensitizes women to make sure that everybody has a voice and is represented.
Yeah, and I think we've got a long way to go, but you know, days like International Women's Day hopefully kind of garner that energy for women to listen to each other and to each other's experiences. So that's great. Thank you so much, and we look forward to hearing more from you in the Q&A. So next up, we've got Dr. Mark Ward. So Mark is a fellow researcher with the Irish Longitudinal Study on Aging, also known as the TILDA study with Trinity College Dublin. So welcome, Mark. We're delighted to have you today. So if you'd like to tell us a little bit about yourself and the work that TILDA does.
Yeah, thank you, Mary, and everyone for inviting me along today. It's great to see such interest in this event. It's a really crucial topic. So, you know, the louder we can talk about it or shout about it, I think the better. So I suppose to begin, my name is Mark Ward and I'm a research fellow with TILDA. I'm a sociologist by trade, so I am delighted to hear Fiona and Clena talk about social inequalities and structural reasons for these inequalities, because essentially what we've seen during the COVID pandemic is the magnification of existing stressors and inequalities. A lot of the things we're seeing now existed previously. So, you know, the essential workers being predominantly female, you know, the caring role of both children, grandchildren and spouses and so on. And we've known all these pressure points existed. And I think what's happened now with the pandemic, it's just they have been amplified many times over. And one good side effect, if you want to call it that, is I think there is more of a public awareness around those issues and a discussion around them. So hopefully that will continue and we can actually make some positive change. So on TILDA, so TILDA is the Irish Longitudinal Study on Aging, and it's a large nationally representative study that have been conducting interviews and health assessments with older adults for over 10 years now. So back in 2009, the study recruited 8,500 adults aged 50 years and older. And we go back to those every 2 years to conduct interviews and every 4 years to conduct full health assessments. And TILDA is very much multidisciplinary. So Clena has done some work with the data, but we have clinicians, psychologists, economists, epidemiologists, and as I said, I'm a sociologist. So it really gives us a very broad view of the lives of older adults. A key strength of the study is that it is longitudinal, so we return to the same people every 2 years, and that way we can really, you know, see exactly how aging happens and what the I suppose the things that help the aging process and those that can be damaging to it over time. So back in May, it's hard to believe, it's almost a year ago now, the Health Research Board provided funding for a COVID-19 specific study. So in June, we posted 4,000 self-completion questionnaires to TILDA participants, and the express aim of that study was to try and find out what exactly, what exactly the impact of the pandemic on their lives. So I'm going to show you some of the results from this. I'm going to share some slides to do that, which hopefully will go smoothly, but I think just visually it really brings it into stark focus just how damaging the pandemic and the restrictions have been for many people's lives. So fingers crossed this will go smoothly now.
Yeah, we can see that there.
Okay, perfect. I'll just try and get on the presentation view. Okay, great. So this is a report that we published at the end of January, and this is kind of the initial findings from the study. There's an awful lot of work still to be done to go into the detail of it, but we cover an awful lot of what has happened to the lives of older adults in the early months of the pandemic. So things like changes to everyday activities and social participation and so on, people's levels of concerns and their exposure to the virus, loneliness, which I have a particular interest in, have written quite a lot on in the last couple of years. Also how people's physical activity, sedentary behaviour and so on have changed, and the impact on their mental health, which I'll describe in more detail in a second. And we've also looked at the use of healthcare services, or rather non-use. So there's a lot of unmet need there among older adults and others where healthcare services were cancelled or postponed. And we also look at changes to caregiving roles. Now, a lot of the topics covered in these are things that we've shown until over 10 years now are really, really important to people's well-being. We're social creatures, you know, when we look at people's quality of life and their life satisfaction and their mental health, the things that are really important to them besides their own physical health is their social networks, participating in social activities, the kind of sense of community and these types of things. And we can see from the restrictions that, you know, a lot of the things that kind of aided well-being or made people happy and got them up in the morning have been taken from them during the pandemic due to the necessary restrictions. So just to look at some of kind of the specific findings that we have. So looking here at loneliness, and this graph, what we're showing here is on the left-hand side, the average loneliness scores and a measure we use in 2017 and then in 2019 and finally in last summer. And what you can see is over time, and this holds true even when we track back further, there's very little change in terms of the level of loneliness one year to the next. And then we see a massive increase brought on from the start of the pandemic. And obviously this is driven by people feeling isolated, by not being able to interact with family and their social networks. The Central Statistics Office, and this is data from November, so only a few months old, and they found that in all adults aged 16 and over, that 17% of women reported feeling lonely all or most of the time. And that's about 4 times what we'd normally find in a normal year from TILDA data. And this is massive repercussions for people's well-being and their life satisfaction. So another one of the kind of well-being measures we included in the survey was on levels of chronic stress. So this is based on a series of questions, and as you can see, in previous years, women had slightly higher, reported slightly higher levels of stress, but this difference between women and men has increased more so during the pandemic. And again, we see this awful inflection point where stress levels increased an awful lot from the start of the pandemic. The last one of these is in depression. So we use a measure called the CSD-8. Now, it's not a clinical tool, but it's commonly used in observational studies. And again, similar pattern. We see not much change over the preceding years, and then a huge increase from the start of the pandemic. And I think when we look at this in terms of what we call clinically significant levels of depression based on this measure, again, you see the inflection point, but I think the prevalence rates are really shocking. So we go from in around 8% for women in previous years and less for men, and that's almost trebled now to 23%. So like 1 in 4 women aged 60 and older last summer you know, reach the bar that would be considered clinically significant depressive symptoms. And I think it's really important to bear in mind that this is from last summer as well. So the fear would be that the situation is likely worse this time around on the back of the last lockdown, which seems to have been going on forever, and also people's, you know, its exposure to the virus itself. So again, the numbers would have been really low in terms of the number of cases and the death rate, and people kind of being affected in that way, and that's obviously, you know, many multiples over the last couple of months. So Clena and Fiona both touched on the role that women play in providing care, informal care. And again, we've consistently shown this over the years with TILDA, that the burden of informal care falls largely on women's shoulders. Among this cohort, some of that care is caring for people's spouses and other family members. We've also shown over the years that like 40% of women in this group provided care for grandchildren on a regular basis, some full-time. So though that burden, I suppose, as I said at the beginning, has been exaggerated now. It's not a particularly new thing, but it has been exaggerated. And you see that reflected as well in the findings from the Central Statistics Office, just at the bottom here, where it just shows that one of the big stressors in terms of the types of concerns that women have, it is about other people's health. And I think that reflects the kind of burden of informal care that women, and in this case older women, take on. So that's it for the slides, but I hope that gives you kind of an indication of just how dramatic the effect has been on people's well-being. And as I said, you know, there's lots of resources on the TILDA website. There's that report and other brief reports that you can kind of dig into the detail of.
That's great, Mark. Thanks so much for sharing those results. It's a really important study, the TILDA study. I think, you know, these kind of lifespan approaches are always really important because, you know, women, they're not a homogenous group, but for women at certain stages of their life, you know, often experience similar things. So it's a good way, a positive way, I suppose, to approach solutions. So on that, I'd love to hear, I suppose, what you think the opportunities are for change. So moving out of lockdown, and I understand we're still in lockdown, and
yeah,
we don't know how long it's going to last, especially for older peoples. But yeah. Yeah.
So I have a wish list, which I'll go through in a minute. But in more general terms, I think public discussions like today are key. Like, a lot of what we're seeing is a perfectly normal reaction to really extraordinary circumstances. And I think as a population, as a society, I think that's the first kind of step in trying to emerge from this. That there's still, as we all know, a lot of stigma around mental health. But the fact of the matter is, this has really impacted on everybody's lives. It's exacerbated some of the inequalities that we have known and have been talking about for years and years. And I think, in a sense, we kind of face a choice now. We do have a choice. One is we go back to let things kind of drip feed back to normal and hope that everything takes care of itself, or actually take the opportunity to say, okay, you know, there's a stop in the system or the circuit now, so let's take the opportunity to actually do things different and come back better and bring everybody back better, and not just kind of settle for let's get back to the way things were. In practical terms, like, we have to be cognizant of the fact that people's mental health has been badly damaged over the last 12 months. So in terms of practice, you know, we need to identify who those people are. Like as Clena pointed out earlier, we already know, like among healthcare workers, and indeed a study we did of patients within James's Hospital, that the rates of psychological distress and depression are even higher. So I think clinicians have to take that opportunity when they do have face-to-face contacts, again, of screening as best as they can. And I know there are time constraints, I know there are constraints with this, but I think we have to try. So on my wish list, but first up, we've got to get vaccinated. I think this is the great hope. I think Ireland doesn't compare too badly to other countries in terms of kind of fears or reluctance around vaccinations, and that's even less so among older adults. And I felt like anecdotally, at least, like a lot of the people in our TILDA participants, they remember things like polio, you know, they remember measles. So they've lived you know, through the benefits of previous vaccinations. So I think that's the first thing to help us try and get out of here. We've got to try and address some of the structural reasons for the inequalities that have been touched on already. There are things like flexible working arrangements. There are things like properly state-funded and supported childcare. They're properly funded and resource community healthcare services, and services like you know, respite care and the like, to take the burden off individuals. And you know, as we've seen, it falls more so on women. We need to take the opportunity to change the built environment. You know, like, I'm delighted now, this is probably a very Dublin-centric and cyclist-centric response, but to see the infrastructure being changed in the city to make it more commuter-friendly, cyclist-friendly, walking-friendly, green spaces. We need places for people to be physically active. We know physical activity is usually beneficial for physical and mental well-being. We also know that there's a reluctance, and particularly among older women, to go out on dark evenings because they don't feel safe, and pathways are poorly lit and so on. So we have to provide opportunities for people to be more active when that's what they want to do. And finally, I think we need to get ready now and support community groups who are working on the ground and actually, you know, have access to people. And they're the groups that are the first responders, if you like. And they're the groups that can react quickest within their own communities to the needs of not just older adults, but everybody, as we hopefully find our way out of this.
Yeah, that's great. I love how you've named it a wish list. That makes it seem very hopeful. But you're absolutely right. You know, I think there has been a massive reliance on people in the front lines within communities, and you know, there continues to be that reliance. And if we're going to, I suppose, provide the care that people need, especially older people, you know, there needs to be increased funding there, and there needs to be ring-fenced investment.
Yeah, and as I've said, and Clena's pointed this out, these are not new stressors or pressure points. They've always existed, or they've existed for a long time. People kind of fill them, and there's band-aid responses to them. And I think that's our choice now, is either we really go at this and try and address those inequalities and those pressure points, because, you know, going back to the way it was, it'd be the same people again who actually won't get a chance to re-emerge, you know, from the pandemic.
Yeah. Well, thank you so much, Mark. That was really informative. I'd love to keep chatting, but I'm just conscious of time, and we want to give everyone who's watching just a little break. So we're going to just break for 5 minutes, and we'll come back at 2 to 3. So just remember, you don't have to exit the webinar. You can just leave it open. But if you do accidentally exit, you can just click the link that you received in your email this morning. And after the break, Elaine Donnelly from St. Patrick's Mental Health Services, and she's also a coordinator of the Women's Mental Health Network, will be chairing a discussion with our panelists and will take questions from the Q&A. So if you want to pop any questions for our panelists, you can do so there. So see everyone in 5 minutes. Thank you.
Okay, welcome back everybody. I know that was a short but brief break, but I'm sure well needed. I really enjoyed the 3 presentations, so I'm all geared up for a good Q&A. My name is Elaine Donnelly. I'm social work team leader in St. Patrick's Hospital, and I'm also one of the coordinators of the Women's Mental Health Network along with Mary and Louise. So we're going to do a Q&A section with our 3 panelists, but before we do that, we were going to invite a poll with some feedback from participants. We're really missing the energy and the feedback that we get from everybody in the room, so we thought we'd do a short poll, and then we have some specific questions. I know I have some of my own questions as well that I'd like to get going. So I'm going to launch the poll now, and we'll take a few minutes to get some feedback, and then I'll invite the 3 panelists to unmute, and we can get the discussion going. So the poll is really asking for feedback on whether we think women's voices have been adequately heard in the response to the pandemic. Okay, lots of votes coming in. Okay. So just give it another few minutes. I think we nearly have everyone who's voted. Okay. So I'll just publish that there. So you can see from the results that the majority of our attendees today really feel that women's voices have not been adequately heard in the response to the pandemic. And I think that that's been really clear from all of the presentations and discussions so far. I just wanted to start by inviting our 3 panelists to unmute yourselves. We will be continuing the Q&A, and we'll try and get through as many questions as we can. So feel free to use the Q&A function, and Louise is working away in the background to collate the questions. I might just start by asking you what you guys think of the poll results there, and have you any thoughts on each other's presentations or anything that was raised?
So I was really struck by the data that Mark showed about the increase in depression and loneliness and isolation. I hadn't seen that data before. It was really striking. And I loved Fiona's presentation, and I couldn't agree more about an excess of reports and a lack of implementation, particularly regarding mental health in Ireland. Yeah, so, yeah, both fantastic. I learned a lot from both the presentations. Yeah. And I want to know who strongly agrees women's voices have been adequately heard in the response to the pandemic.
Yes, I'm not sure about that.
That was me.
You, Mark.
I think, Elaine, as well as like women's voices, it is those excluded. It's that intersectionality between, you know, poorer women or less, you know, more excluded women certainly haven't been heard.
Yeah, I think in some respects, it comes to power. Like, who has the power has the louder voice. And I think where Clena showed her slide about more, gender egalitarian or gender equal societies tend to have more female-friendly policies around childcare, flexible working, and so on. That's what that reflects, is that having the power to implement change. And as I suppose been a theme of today's discussion, the people most affected of these have always been the more disadvantaged or the least advantaged in these scenarios, and are always the ones without voices. And unfortunately, it depends on discussions like this to try and amplify those voices, because the opportunities aren't afforded to them.
Yeah, and I think there's no doubt that existing inequalities have been really, made things much tougher and much more dangerous for some people rather than others. And that's very clear. And I know as a social worker, that's something that I really was heartened to see you all speaking about, the role of social inequality and the role of social justice in how we move forward and how we start to make changes and start to maximize these opportunities. And I might start with that question, I suppose, to think about how we can really take practical steps to address the social determinants of mental health, because we know that to really address individual mental health, we need to create and invest in supportive environments.
Well, Elaine, my social work colleague Niamh will be so proud of me. No, all her work has paid off. I think one that I'd love to see, and again, I've learned it from Niamh, is a rights-based approach. So there's been a movement recently to put a right to housing into the Constitution, and I think that would be a really concrete step to address a major structural determinant of mental ill health.
Absolutely, yeah, absolutely. That right to housing.
And maybe a right to psychiatric services, within a timely fashion or something, because, that's so striking.
That legislative backing, absolutely, Clena. Fiona, were you going to come in there?
Yeah, I was just going to say, like, one of the really important things for me is that, we have a policy that recognises is my voice gone funny?
No,
oh, sorry. Sometimes my microphone acts up. No, I was going to say it's the ownership of mental health outside of the HSC and outside of the Department of Health. We need justice. We know women in prisons are not getting access to the supports. We know, that social welfare benefits, I've seen some comments come in, like that social welfare benefits need to be reassessed and re-looked at in terms of, people with mental health difficulties in general. And then, carers within that who do take on kind of those roles. So for me, what I'd love to see is kind of other governments take ownership of some pieces of our new policy. But unfortunately, in Ireland, we don't do cross-governmental policies very well. And, the situation where it is at the moment, if there's something to be done around mental health, other policies or departments are going, well, the funding needs to go over there. That's health. The Department of Health needs to fund that. Well, it's really no. Whether it's, and it's whatever project it is or program, people need to recognize its value and its importance. And just the second thing, Mark, I loved your presentation as well. And there's a lot of data coming out of the UK in particular. At the beginning of this pandemic, there was a lot of discussion around we're all in this together. It's impacting mental health across the board. But the reality of the matter is that some people are more resilient than others. And what we're finding now is that there are certain groups that do need specific investment, like frontline workers, like older people. We know that the HSE, one of their increased demands is the psychiatry for later life has skyrocketed in terms of requests. So I feel we're not quite there in Ireland. We're very reactive. We kind of jump into things while really pressing pause and going, okay, they've committed 10 million 2 weeks ago into mental health services. Where should that go? What's the evidence telling us? Where should we invest that? Rather than just kind of, oh, great, let's have another kind of mental health population-wide campaign. You know, we really need to be more strategic as a country, I believe, in how we approach healthcare.
Yeah, no, absolutely. And like the first thing I said, anybody who ever says we're all in this together, apart from making me smile, I suspect they're probably among the least impacted by it, because again, it's exaggerating existing inequality. We're never all in this together, but everything is socially patterned. There's structural reasons for those patterns, and I think you need to be in a really privileged, protected position to be able to say, oh, sure, we're all in this together, we'll trudge along, because that's simply not the case. In terms of implementation, what we can do, like again, I think the role of community groups and people working on the ground is really key. Like, you know, a big national information campaign on loneliness is going to do very little to address loneliness among different groups. Groups on the ground who are actually, you know, giving opportunities to people within their community, for me, is the key to it. And like as a starting point, I suppose what we're conscious of within TILDA and wider research is, as a start, but you have to identify who these groups are in the first place, I suppose, and then you can begin to target it. Just finally, and maybe a little circuitously, the word resilience is being used a lot around, you know, will people be more resilient to, or certain groups be more resilient to? And it's a term I kind of increasingly dislike, because it's almost circular or after the fact. So you've done okay, therefore you are resilient. You know, so I don't think it kind of helps the conversation that much, and I kind of worry about how much the discussion, particularly around older adults, trying to be, so will the, you know, the super agers, will they be the more resilient and they'll all be okay? Let's just follow what they do. We know who they will be. They will be the one with the greatest resources and supports to be able to navigate the pandemic, and it'll be the same people who will lose out, as always. And it cheapens it to say, oh, they're just not as resilient, which is, you know, the natural flip side of saying that the successful ones are resilient. I've wanted to rant about that for ages. So
I could join you in that rant, Mark. Absolutely. It's a very complicated term, and certainly completely underplays the resources that it takes to be resilient, or whatever that might mean for each individual. But the role of the community in that, I think, is really important. I suppose there's some specific questions, and I think it's really great to hear you all talking about the role of legislation, the role of strategy, the role of policy. All of these things on a macro level are so essential to how we move forward and how we really build on this, because absolutely it's created an awareness, but it needs to go beyond that. We need something to change now, and we need something to be different, particularly for those people who have been disproportionately affected. And I know coming through from the chat is that, you know, we can hear from people who have really been disadvantaged by the withdrawal of already under-resourced essential services for parents with disabilities, for carers. And I think a question is coming in about around how can we ensure the Taoiseach and the Cabinet COVID Committee and NPHET, etc., demonstrate they understand the impact on women and actually take steps to address the impact on women? Because it's recognised that there's been increasing discussion around it in the media, but how do we go beyond that, and how do we ensure that they take actual practical steps? Does anybody have any specific thoughts on that one?
So I think something that could be considered is around quotas, quotas in, you know, in politics, quotas in decision making in terms of gender equity, but also other types of equity. And I think, you know, they often have been shown to work. People are loath to bring them in for many reasons. But, you know, if, the people who are making the decisions, if they're very homogenous, they're not going to consider, it's not going to come to their mind the impact of certain decisions on certain people.
And I think, like you mentioned, Clena, the clothing, the restrictions on buying essential clothing, for those who met the Easter egg wall in Tesco, if you're buying for small ones. Yeah, absolutely.
And lots of people don't have credit cards and can't order online, you know, so it's just that, not being visible.
Yeah, absolutely. So quotas are certainly
that would be something that I would.
Yeah,
that notion of visibility is really key. Like something I've kind of noticed in a lot of certainly government level policy, when something's happening behind the door, you know, whether this is a legacy of, you know, the place of family in the Constitution or whatever, they're reluctant or seem to be reluctant to get involved in it. And in many ways, I think it's kind of an easy cop out in that it's behind the family door. It's the family responsibility to do it. And as I said, unfortunately, a lot of the stresses we're seeing do happen in that realm in terms of the burden of care and schooling and so on. So I think the trick is maybe try and make that more visible. And whether that's through, as Clena suggests, greater representation of women in the legislator or whatever other method, you know, like the thing as well is it's not a blank sheet here. We see how other countries do things better. So we don't necessarily have to reinvent the wheel. Look for the best in class. What's happened there? And try and, you know, replicate what they're doing and hopefully get as good results from it.
Yeah, and to be led by the evidence in that regard, what we know has worked in other countries.
Yeah. Maybe if I could jump in there, Elaine, and one of the interesting things for me, I spent part of my career working in international development, and we know, you know, every year there are so many humanitarian crises, and, you know, there's pandemics or epidemics, you know, they're not new globally. And in these circumstances, there's lots of gender mainstreaming happening. And it's really interesting because in Ireland, we're so proud of our aid programme and it does amazing work. But then when it comes to us implementing a gender mainstream approach during a pandemic, we're met with, well, you know, it's a crisis, we need to go for a whole of population approach. But, you know, that's not what we're saying outwards to other actors when we're giving them humanitarian funding. So I think that's quite interesting that, you know, there is, even from kind of these more the humanitarian fields, there's a lot of learning on how during a disaster or crisis you still maintain, you know, or identify the greater risks that there are to women, to children and girls during these periods. But there hasn't been space for that, and we're kind of in crisis mode, moving from one comms crisis to another. Perhaps that it's about taking that pause and that break and seeing how these things, where the lessons are. And as Mark said, you know, I don't think we need to reinvent the wheel here. There's lots of examples out there of countries who are doing this a lot better than we are.
Yeah, I think it's taking stock of that, Fiona, isn't it? And being responsive rather than reactive, when you like jumping from one crisis to the next. There's a question coming in, and I suppose it's probably connected in a sense to what we're talking about around broader policy changes, but a participant has asked what the panel might think about what we can do to reverse the policy of not allowing partners support people to attend maternity hospital appointments, given that the risk of the partner attending this appointment is vastly overshadowed by the mental health impact for women going through these journeys. Does anybody want to answer that or speak to that?
I think on some level, part of that is to do with how we deal with risk in Ireland, and sometimes how we will do something, we will not allow something to happen because of a small risk, but actually by not allowing it to happen, we're creating a greater risk. And that's probably partially to do with our medical legal system and our culture. You know, sometimes we can be a bit finger pointy, like you did this wrong and, you know, you're going to get slated. But I think it would be great on a societal level to be able to start looking at those risks in a different way. And actually nursing home visits would be another one where certainly, you know, outdoor visits or safe visits could be facilitated, and for dads in maternity wards or partners in maternity wards as well. I think as well, something that maybe not all the advice has been updated quickly enough is around the relatively low risk if people are wearing masks. You know, and if the partners are wearing masks, you know, adequate grade surgical or whatever masks, that's actually a pretty low risk thing to have when you weigh it up with the impact on the mother's mental health and other factors. I feel really sorry, having had kids pre-pandemic, I feel really sorry for women who are trying to go through this without having a support person there. I don't think I would have been able to do it.
Yeah, absolutely. But I think that's a really valuable point, Clena, particularly you know, in this instance for mothers going through that, but also for people who are separated from their loved ones in nursing homes and have been throughout the pandemic.
I mean, and TILDA has lovely research showing, you know, the effect that, you know, and I suppose again it's around mental health and physical health being seen as different things, and health and social factors being seen as different things. It's all part of the same problem in how we work, how we operate at the moment. But TILDA has shown that loneliness has a really profound impact on your physical health. So denying nursing home, you know, residents access to visitors is going to impact their physical health.
Yeah, absolutely. And I think, Mark, your presentation really highlighted that, the role of the community and the role of social supports in keeping people well and connected.
Yeah, like over the years, like we do know what people do to age well. Like again, it's not, you know, it's not some mystery as to what people do and what's important to people's lives and people's well-being. So the key is to provide those opportunities for people, for everybody to do those things, and not just a few.
Yeah, absolutely. And actually on that, Mark, we have two questions for you. So is there any evidence women who do not retire at 66 but keep on working do better mentally or physically?
I love this question. It's one of those seemingly simple ones that I could talk about for hours. So firstly, I suppose the age, the arbitrary age cutoff is a nonsense in many respects. People are living longer and healthier lives. So you could question the 66 cutoff. More important, it depends why you're working beyond that age. If you work in a job with a lot of control and a lot of autonomy, and a job that makes you feel better and a sense of purpose, brilliant. You know, if you're still capable of performing that job, 66 should not be, you know, I'm 65 today, I turn up and do a good job, I'm 66 tomorrow, nothing's changed, I've had a good night's sleep, you know, I'm not all of a sudden, you know, non-productive or whatever the case may be. If, on the other hand, you're having to do manual labor or menial labor to simply put bread on the table, maybe for you and people who depend on you, but then that's not good for your mental health or your well-being or your life satisfaction or your quality of life. So in my mind, it depends on the reason for it. And I think that's an important conversation we need to have when there's a lot of discussion around increasing pension ages and so on. You know, that's fine if I'm sitting in a nice warm office with a lot of control, maybe power and a sense of purpose, and I want to go out and do it. Not if I'm having to drag myself out of bed at 4 a.m. to do a possibly manually demanding jobs that I take no joy from, but it's just a necessity to survive from one day to the next.
Yeah, and that's exactly it, Mark. It's the role of resources there, isn't it? And the structural factors, absolutely. Yeah. Mark, there's also a question about can you become a participant at TILDA, or how you might do that?
No, it's the short answer. So, but they're getting too technical on it. So one of the great strengths of TILDA is that participants were selected randomly. So that means there's no biases in it where certain groups might be keener to join. So, you know, people were contacted almost 10 years ago and then followed up through. So there's no way to kind of, you know, choose to be a participant in it.
Okay, thank you for that. Absolutely, a strength of the study in itself. So we're just coming up to, I suppose, our time. Unfortunately, I think we could go on with this discussion and the energy around it. I just like to thank you all for joining us today. It's been a really fantastic discussion. I would say it's just the beginning of this discussion from our end, and as Mary said, we're conscious that we would, you know, we have highlighted that certain voices have been invisible and marginalized, and we want to focus in on that bit more over the coming events. So certainly that'll be something we'll be focusing on, and something that you've all raised is the role of inequalities and how these existing inequalities have been affected by the pandemic. So absolutely, that's something we really need to be thinking about, and how policy, legislation and action will focus on that as we come out of the pandemic. But thank you all, and thank you all to those who've been working in the background. Louise has been working away on our chat and Q&A, and thank you all to all our participants for attending today. It's been so great to have you all, and we'll be circulating a recording of the webinar and also details on how to join the network if you're not already a member. We'd love to have you. And if you want more information on that, you can contact Mary H at NWCI.ie. But thank you all, and wishing you all the best wherever you are.